Right, so we're going to pick up from where we just left off with. So we're going to now review the evidence for the different systems of memory that we discussed in part one. And the question here is, where does the systems view even come from? And it actually originated largely from neuroanatomical studies. So these are studies usually conducted with patients who have had parts of their brains removed, often through surgery. And the question here is, when a specialized brain structure is removed, and there is memory loss associated with that, does the patient lose all types of memory, or is this memory loss more selective? Do they only forget how to do specific types of things, or are they only forgetting specific types of memories? And the most famous case study, which you've probably heard about in many of your other courses, but if you haven't, be a little nosedive into that today, is that of H.M., or Henry Molaison. Now, H.M. had the unfortunate circumstance of being born with severe epilepsy. So he experienced severe epilepsy throughout adolescence and into early adulthood. And in fact, it was so severe that in 1953, his surgeons performed a temporal lobectomy. And this is simply a removal of the temporal lobes. Now, the temporal lobes are part of the brain which house, among other structures, the hippocampus. And as we'll come to find out, largely from HM, the hippocampus is actually quite critical for learning and memory. And so what happened with HM was both his left and right temporal lobes were removed. So if we look at, here's a scan of a normal brain, here's where the hippocampus is located in the normal brain, so this is part of the temporal lobe. In patient HM, both the left and right hippocampi were removed. And what ended up happening was, well, his epilepsy was cured, but unfortunately he had complete amnesia. And the types of amnesia he had were both anterograde and retrograde amnesia. And the distinction here is that anterograde amnesia refers to an inability to form new episodic memories. So these are memories formed after the event. So think after starts with an A and anterograde starts with A. So you need to distinguish that from retrograde amnesia, which is an inability to retrieve episodes from before the event. So patient HM had complete amnesia, so both anterograde and retrograde, and this is in contrast to some patients who have only one or the other type of amnesia. And so he has this impairment in this ability to remember episodic memories. However, he still had preserved procedural memory, so memory for procedures. And one way this was evidenced with what's called a mirror drawing task. And this is actually quite a complex task. And the basic illustration of the task is shown in these two figures. So here's a shape that is projected via a mirror, and this is meant to fill in for HM. There's this divider here where he can't actually see what he's doing. He has to look through the mirror to monitor. Here's the shape he has to draw. In this case, it's a star. And he has to try to get this shape correct. Now, over repeat trials across days, we can see that the number of errors he made, so to say the number of errors he made in drawing that star just by looking at it in the mirror, decreased precipitously. In fact, by day 3, he's making virtually no errors. And so this is suggesting that he has learned how to do this task over repeat learning episodes. However, he had no explicit awareness of having learned how to do this task, which would be, again, this distinction that he has some preserved procedural memory, but he has impaired episodic memory. So he also had preserved working memory. Again, this is sometimes referred to as short-term memory. We'll go into much more depth about working memory in our next set of lectures. And so these findings suggest that the hippocampus, which again, the hippocampi were the structures that were removed from his brain, are involved in episodic memory, but not necessarily in procedural or working memory. And this idea that some distinct neuroanatomical structure is related to one type of memory, but not other types of memory, is entirely in line with this idea of there being multiple distinct systems of memory, again, where each system of memory is supported by its own unique set of neural structures. So here's just an insert to show different regions of the hippocampus and surrounding cortices. I've highlighted here in yellow this region EC. This is the entorhinal cortex. But actually, patient HM didn't just have his hippocampus removed. He had a lot of the surrounding tissue around his hippocampus removed as well. And this includes EC, or the entorhinal cortex. And later research has actually shown that the entorhinal cortex is important for relaying information, say sensory information, that's being processed into the hippocampus. So some of this later research suggests that it's not necessarily the hippocampal removal, but actually the hippocampus plus also the removal of the entorhinal cortex that played a pivotal role in HM's amnesia and inability to form new episodic memories. So we've discussed a little bit about when specialized brain structures are removed, does the patient lose all types of memory? So with HM, it seems this was the case, that he only lost one type of memory actually, and that was selective memory loss. We can also ask whether atrophy to neural structures, so a deterioration of the neural structures itself, say a deterioration of the hippocampus, and this could be in the absence of actually removing that structure. Does this cause selective memory impairment? And one way we can look at this is through dementias caused by things like thiamine deficiency. So one common, well, I wouldn't say it's particularly common, but one severe type of disease is Korsakoff syndrome. And Korsakoff syndrome is a chronic memory disorder that's caused by a deficiency in the vitamin thiamine. And the depletion of thiamine in brain cells causes atrophy, so the brain starts to shrivel up on itself in specific regions, in large part because neurons are just dying. They're not getting enough nutrients that they need from the thiamine. And this leads to cell death, can also ultimately lead to death in general. Commonly, Korsakoff syndrome is related to alcohol abuse, but it also can arise from certain cancers. And Korsakoff syndrome is a type of dementia that's associated with anterograde amnesia, so an inability to form new episodes. And it's largely this atrophy of the brain occurs in the hippocampus, which, as we just illustrated with patient HM, is largely involved in episodic memory. So here's a control brain, just a normal brain. This yellow highlighted region is showing towards where the medial temporal lobe, so the hippocampus, is located. And in the patient with Korsakoff syndrome on the right here, we can see that the ventricles, so these enclosed, these darker areas, these are areas that hold cerebral spinal fluid, or CSF. These areas are actually enlarged, in part because the actual structures of the brain themselves have atrophied so much that it's caused this enlarging of the ventricles. So this patient with Korsakoff syndrome is showing atrophy in the hippocampus. So all this is to illustrate that episodic memory seems to be particularly susceptible to loss. So we've seen twice already now with Korsakoff syndrome and with patient HM that episodic memory is especially vulnerable to decay, to loss. And this is quite interesting when you think about it. Episodic memory, as I mentioned earlier, is evolutionarily the most complex and advanced memory system. Whereas your less complex memory systems, systems of memory that are shared by basically all living organisms, things like procedural memories, tend to be less susceptible to loss, or less vulnerable to loss, that is to say. It's also easy to illustrate how episodic memory is particularly susceptible to loss when you look at patients with dementias. And so the most common dementia is Alzheimer's disease. Now, Alzheimer's disease, as you may know, is severe deterioration that occurs, severe neurodegenerative disorder that affects mostly older adults. It accounts for about 60 to 80% of all dementia cases. Some of the biomarkers of Alzheimer's disease are an accumulation of beta amyloid plaques. So here's an illustration of that. So these are neurons, and these plaques begin to form. And these plaques essentially starve the neurons of essential nutrients, and those neurons just die. There's also neurofibrillary tangles, or tau tangles. And these amyloid plaques and tau tangles cause neuronal apoptosis, brain atrophy, and ultimately death. Now, as I mentioned, the greatest risk factor for developing Alzheimer's disease is actually aging itself. But there's also genetic predispositions that put people at risk, of course. It tends to first affect episodic memory. So it starts targeting regions like the hippocampus. You see this progression of Alzheimer's disease is atrophy of the brain. But it also later begins to affect things like working memory, and ultimately it leads to death.